So I'm here to review the consensus statement that was recently published in the Journal of Trauma and Acute Care Surgery, titled "The Pediatric Traumatic Hemorrhagic Shock Consensus Conference Recommendations." In this, they did a 16-member multidisciplinary panel that got together to make recommendations for pediatric hemorrhage shock treatments. First and foremost, this is impressive because they got 16 people in the room at the same time and got them to agree on almost all these things with very high agreement rates. One thing I do really want to highlight is the fact that there was 100% agreement on the use of blood over crystalloid. I hope that the practice of using crystalloid to resuscitate after trauma is soon or already has been taken behind the barn. I think the data on that is overwhelming. I'm just going to give you a kind of a summary of the recommendations here. This document is pretty dense with a lot of information, so I'd recommend reading it yourself. I'm going to kind of highlight some of the key points here, though, and things that they generally had pretty high agreement on, and a lot of these actually had 100% agreement on across the panel. So first, in traumatically injured children with hemorrhagic shock, we suggest prioritizing the use of blood products over the use of crystalloids for resuscitation. Number two, in traumatically injured children in hemorrhagic shock, they recommend the use of low titer whole blood be considered, if available, over individual components. Number three, when resuscitating, they recommend the use of high plasma to red cell ratio with a 1-to-1 preferred. Four, when resuscitating using platelets, they recommend a 1-to-1 ratio as well. Five, in the pre-hospital setting, EMS should be able to consider and have the ability to perform a blood transfusion when resuscitating after hemorrhagic shock. Six, they recommend that TXA be considered within 3 hours of injury. Seven, they recommend that TXA be considered over aminocaproic acid when you're looking to administer an antifibrinolytic drug. Eight, they said there's insufficient evidence this time to support the use of prothrombin concentrate complexes. Nine, there is insufficient evidence to recommend the uniform use of viscoelastic monitoring to guide therapy. However, they did state that they do recommend using it if you have it available. So I take that to mean that if you have it, great. If you don't, at this point, there's not sufficient data to justify pulling out your credit card quite yet. Number 10, there's insufficient evidence to empirically administer cryo or fibrinogen concentrates empirically. However, number 11, they do go on to suggest the replacement of fibrinogen only when levels are low. So if you have a low fibrinogen level, consider replacing it. 12, they recommend use of commercially available tourniquets by trained personnel. 13, in the pre-hospital setting, they recommend the use of age-adjusted permissive hypotension. In 14, they recommend the implementation of a massive transfusion protocol to guide therapies and manage your blood products. Drop your comments below and let me know what you think.